So, welcome everyone. Today we are going to have a session regarding complications in the epilepsy surgery techniques and also complications in the epilepsy surgery invasive recording techniques. And this is important. Like in any other surgical procedure, it's very important to have a good sort of thinking of the pros and cons. So we're going to give a short introduction. I'm going to give a short introduction, then we're going to have some discussions with the other colleagues. So first, complications on invasive diagnostic procedures and of the surgical procedure in epilepsy surgery. So I am Bertil Rydenhag, I'm professor of neurosurgery in Gothenburg. Actually, my chair is dedicated to epilepsy surgery. So seizure freedom or substantial reduction of seizure frequency and severity, that's the goal. We have the goal of improvement in health-related quality of life. And if possible, also a good cognitive outcome, no surgical complications, and no expected deficits. So what is success of epilepsy surgery? Of course, we all want seizure freedom. Of course, the patient wants it the most, and we also, all around the patient, want it. If you cannot get a seizure freedom, you would like to have a worthwhile reduction of seizure frequency and or severity. Sometimes we have to focus on palliation, less traumatization, halted cognitive decline, halted behavioral decline, AED discontinuation, quality of life improvement, and finally, no downsides. We don't want any surgical or neurological complications. We don't want an increased seizure frequency. We don't want a double-loser situation. We all know that the expression of double-loser situation is a patient that still has the seizures left, perhaps a little bit less frequent, but have also a neurological deficit. So that's the worst situation. And it's very important when you discuss regarding the epilepsy surgery team. We have in the team a neurologist, several neurologists here. We have a neuropediatrician, neurosurgeon, clinical neurophysiologist, neuroradiologist, neuropsychologist, epilepsy nurse, and more. And it's very important that the full team is with you. And I can say I've been working with this for more than 30 years. And this team has been with me when I performed the surgical procedures, and they have supported me and my young neurosurgical colleagues with support, and that is important. So what about the patient? We all have different algorithms, okay? Is the patient operable? We have a history, we have a semiology, and we have a hypothesis of a seizure generator. We have a non-invasive evaluation. And a non-invasive evaluation, they are so important because as soon as you leave the non-invasive evaluations and go to invasives, then you take further risks. But to the left here, you have the most simple situation. You have a lesion and you have a congruent findings. You can make a decision on surgery. You may make a decision on lesionectomy. It could be cavernoma, it could be a temporal lobe resection. It could be a model Spencer or something different. And then the other situation, which basically is also quite easy, but sometimes a little bit difficult to really make a decision on, is that you have no lesion, you have no congruent findings, and it's not possible to proceed. And then you have this interesting in the middle situations. You have no lesion, that is nothing to be found on the MRI. You have something to be found on the MRI, but you have incongruent findings that you might, or usually you proceed with some kind of invasive evaluation. So let's remember that what we actually do when we talk to a patient or we talk to the parents of a child is that we suggest SCG, we suggest subduras, we suggest callosotomy, we suggest a hemispherotomy, we suggest a displaced resection, or we suggest a temporal lobe resection. And as in all neurosurgical procedures, we have to remember that it is sort of routine for us, but it's the first time for a patient. So if I put it in a little more drastic manner, we actually suggest to put needles in the patient's brain or to cover the brain surface with silicone and platinum recording materials. We suggest to disconnect the cerebral hemispheres to remove a small part of the brain or a visible lesion. We suggest to remove a large part of the patient's brain, or actually to remove or disconnect half of the patient's brain, and in that case it's usually the child's brain. So seizure outcome is certainly one main question, but we have the cognitive outcome, we have the quality of life for the patient and the family, and anti-epileptic drugs, can they be stopped? If a palliative procedure is suggested like callosotomy, I usually think that the gain-risk discussion might even be more important than for a resective, potentially curative surgery. Surgical risk, or even the risk of death in a surgical or immediate post-operative complication, is really important, both for invasives and for the final surgical procedure. And detailed information is really needed. So what about the safety? Due to the anti-epileptic drug withdrawal during monitoring in the epilepsy monitoring unit, we can have increased number of seizures, including status epilepticus. We can have accidents, including fractures. We can have sudden unexpected death in epilepsy. At the invasive workup, we can have using grease, we can have hematomas and swelling. Using depth we can have intracerebral hematomas. And at the therapeutic surgery, we can have infarction, bleeding, swelling, unintended removal of local cortex, and infection. Here I present just some selected references from 2001 to 2021. 2001, we presented, I and my clinical boss, Sivander, we presented the first presentation from the Swedish National Epilepsy Surgery Register involving complication. And then a colleague of mine in neurology has continued this work and presented updated data. And now he is also the first author of a chapter in the textbook by Gonzalez-Martinez et al. So in surgery for epilepsy, there are some clear instances where there's a high risk for of an expected deficit. You can have a visual field defect in temporal lobe resection up to equivalent anopia. You, of course, may get some further verbal memory impairment at dominant temporal lobe resection, or in some instances also a worsened hemisphere syndrome following hemispherectomy, or a hemispherotomy for expected deficits. Those risks, that is something that the patient must be informed about, be aware of and accept, but also be well informed about the risks for true complication. So there is no common classification of complications related to epilepsy surgery. Definitions differ between reports, and this differences both regard severity and at which time evaluation is defined as permanent. So in our paper from 2001, we defined a complication as minor if it resolved within 3 months. We defined it as major, and that was also based on other publications, if it affected the activities of daily life and lasting more than 3 months. But now there are more common international suggestions we choose 6 months. And if the deficit was constituting a major neurological deficit, whether it affects the activities of daily life or not. And just a few years before that, Behrens from Bonn et al. Had a similar classification but different terminology, transient versus permanent. And this is the result from our publication in 2000, and we are in the same line as Behrens. So in temporal lobe resection, we have a major risk of complication for 2.7%, and Behrens had 2.2%. And then my colleague in neurology, John Bjelvi, went through it all again with 863 procedures from 96 to 2010, and the numbers are really in the same level as the first publication. And what is also important is that it's important to be sort of aware of what kind of classification do we have. So Johan Bjelvi and several others have gone through the possibility to sort of unify during a classification of complications. In short, if you have a bleeding after a subdural recording or ECG electrode, but it doesn't mean anything to a patient, you can report it as a subdural hematoma or intracerebral hematoma, and you can report it as no consequence for patients. So that's important, really. So let's just go very quickly through the different procedure, and since you are all very well aware of this, I will take it very quickly. The main procedure that I do or my colleagues do is the Spencer section of the major temporal epilepsy. We take the temporal lobe, and then we take off the medial parts, usually, and especially on the dominant side. I try to spare the dominant superior temporal gyrus. And as we all know, we have some structures in this region. We have the anterior coronal artery, we have the cerebral peduncle, and we have the ambient system, which is very, very important. And if you do a temporal resection, you have even limited. You can have some expected increase of cognitive affection on the dominant side. You can have expected upper quadrant anopia, usually all the materials between 20 to 80%. And this 80%, it's really relating to the publications regarding selective amygdala hippocampectomy, which in a very high percentage cut the major lobes. But nowadays it's possible to avoid it. So this is the publication from National Hospital in 2014, where they used tractography to try to avoid the upper quadrant anopia. And this is a patient I operated using our program, sort of implemented the visual fields, and we can go through and reach the medial parts with a probable DNAT without taking visual fields. Of course, this patient was operated just 2 weeks ago, so I have no result of the pathanatomical diagnosis or no result of the visual field. And this is a very special sort of exception. At least in Gothenburg, we extremely seldom do surgeries like this, but this is a small child, some few years old, with extreme severity of the epilepsy situation, with a polymicrogyria and dysplasia. And it was almost impossible to evaluate visual field before the surgery. But he was operated 1.5 years ago and removed the occipital lobe, and then of course, even if he did have some function in that occipital, he would be hemanopic, and he's now doing extremely well, no seizures and good cognitive relation. And I'm just very keen on stressing that this is a procedure, at least in Gothenburg, that we would never ever suggest in an adult patient in Gothenburg. It must, in that case, it must be extremely sort of special situation. I had a complication some years ago, and then we did a lateral hemispherectomy on a patient that was 25 years old, and we did it lateral, like per-insular millivur, and then you go from the lateral side, and you have to. This was a patient 25 years, operated 2015 aluminum. He came to Sweden with family just a few years before, and of course he should have been operated when he was 2 or 3 years old, but that didn't happen. So after surgery, he got a SMA paralysis in the wrong arm, and we found a ischemia in the SMA area on the left side. And of course, this is due to that. What is interesting anyway is that the patient completely healed and recovered and no problems and seizure free. But this is anyway interesting. Then going to the trade-off with an invasive seizure monitoring. The invasive procedures are purely diagnostic, and they are part of the investigation. And the result may well be that we tell the patient that it's not possible to proceed to a therapeutic procedure. And so what risk can we justify for a diagnostic procedure, possibly ending up with an elective procedure that may be successful in 55 to 75%? Okay, that was many ifs, and but it's important anyway to have this in mind. So subdural strips for bowel organ, the risk is very low, and we know that subdural grids that is not so low. We have a mortality reported, we have brain edema, we have subdural hematomas, we have infection, and then that electus enotype. Generally, we have a low but potentially serious. We can have a hemorrhage, we can have a cerebral edema and infection. This was a publication which I think was extremely important. It came from an Australian group in 2009, Wong et al. They reported 71 patients that underwent 79 intracranial monitoring sessions, and they had a 2.8% mortality. And that was, I think, something like an eye-opener. This is one of the patients. They have placed several subdural grids, and this is another patient with several subdural grids. And the problem was that they placed these grids within the neurosurgical department, and then they transported the patient to a monitoring unit without neurosurgical resources, and they looked after the patients once an hour or something like that. So these patients were really found when they almost really were dead. This report was so important, I think. So their conclusion was that you must have one-to-one rate of the observations. Okay, I don't support the suggestion invasive pressure, but I certainly support that you have to have a person sitting there all the time. So in Sweden, we published our complications from invasive monitoring. We published that 2013. At that time, we had it started with SEG, and these are mainly some complications from the subdural grids. We have had no major complications, and that is due to the fact that we always had a nurse or a nurse assistant sitting by the patient day and night. And of course, we have had incidences. I have been running for 3 minutes from the epilepsy monitoring unit to take the patient down to the surgery to remove the grid. But that is part sort of the deal. But if you have a surveillance like that, then you can avoid remaining severe complications. And then what about SEG and safety? Some publications and comments regarding SEG and safety. Yeah, COSI in Italy have reported on that. And just if you take the publications on average, there is a risk of a major complication of 0.6 to 1.3%. And that is, of course, mainly the intercerebral hemorrhage. And, of course, death are reported. This is a very small sort of complication that I would like just to report. This is we started with SEG in 2013, and this is a complication with an SEG electrode in the frontal area on the left side with a angulated electrode, and we got a dissection by the dura. Of course, this small epidural hematoma didn't cause any damage, and it was just sort of observed on the control CT scan. But I think this is also interesting. It's I will try to, in a humble way, present the learning curve. This is the third patient that I was involved in SEG, and that was just after the summer 2013. And then this is the instrumentarium we used at that time. Now it's a little bit different, but the principles are the same. We drill a hole in the skull bone, and then of course we use a stop screw. And then you use a screwdriver to take the screw, and I didn't use a stop screw. It didn't occur to me. So the screw ended up in the middle of the brain. And after that, I always use stop screw, of course. The patient was not damaged. I mean, this is 2 images, and I have done some summation of the different images. So here's where the stop screw is, and here is after resection, which finally became a medial resection. So I took out the stop screw at that time. But it's so important sometimes when you start a new technique. Of course, I know so many of you have started new techniques, but sometimes you just don't think that this would be a problem. And I didn't, but I learned a lot from that. And that's very important. So conclusions: seizure outcome is one of many outcome variables in epilepsy surgery, but seizure freedom or a substantial reduction of seizure frequency and severity is the main goal. It's important to individualize our aims in relation to patient needs and possibilities. This also means that we have to consider risk of a complication both in invasive monitoring and in the final surgery, whatever method is used. So detailed outcome knowledge, including risks for complications and other negative side effects, provides a basis for a realistic preoperative patient counseling. And finally, never ever leave a patient with intracellular electors, whatever type, without 24/7 observation. Thank you so much.
Well, thank you, Bertil. I think if you could unshare. Okay, perfect.
I will unshare now.
And okay. we need Guy and Jorge back. So anyway, the idea now would be that each of us, the rest of us, would present a complication from our series. We would try to do some polling today, so be ready for some voting on what to do in each circumstance. And if time allow it, I think we should consider what we have called the decision-making complications. We are going to be showing technical complications, but there is the issue of the decision-making complications too. And we are going to discuss that if time allows. So I will go first. And what I'm going to be showing you can you see the screen?
Yeah.
Okay, perfect. So I'm going to be showing you a complication that we had in a DBS procedure. Of course, we are not interested in long discussions of the case. It's mainly a technical presentation, but this is the case. He's a 14-year-old boy with refractory generalized epilepsy since the age of 2. He had bilateral generalized tonic-clonic seizure and absences, extremely refractory, of course, with compatible EEG findings. And I put meds here because I'm sure many of you and us will like to discuss the impact of meds in surgical complication, but he was taking lamotrigine, phenobarbital, and levetiracetam. That means no valproate. He was previously submitted to a vagus nerve stimulation without any response and was brought in for central median DBS. So this is just to show you his. Can you see the screen?
Yes.
Okay, perfect. This is just to show his pre-op MRI. It's basically a normal scan. He had no lesions, no major atrophy, no major anatomical or structural damage. As part of the procedure, after we placed the frame, he went for stereotactic CT to be fused with his pre-op MRI. And this is his intraoperative CT scan. And I'm going to go over it and back to show you what I want to show. So it's a pretty standard CT acquisition. But the one thing you see here, pay attention to this pin here. Let's zoom it a little bit. Okay, so you see it's a pretty thick bone, but this pin here went into the inner part of the bone. So I think, Guy, at this point, we need my first question. Can we do the first polling question? Okay, so you might be able to see it. At this point, what would you do? Remove the frame and abort the procedure. Go ahead with the procedure. reposition the pin, this right frontal one, and go ahead with the procedure. Reposition the pin and repeat the CT an hour, or maybe any other. So I think is the poll open, guy?
Yes, it's open.
It's open.
Yeah. Okay, so that's allowed a minute or so for the people to vote. I could show the other pins too, but the other pins did not come through, just this one. So most of you would recommend reposition the pin and repeat the CT in an hour, or simply go ahead and remove the frame. So, but contrary to your suggestions, we decided to go ahead with the procedure. And we've got an uneventful centromedian DBS implantation. And as usual, our patients get intra-op post-op CT or immediate post-op CT. And he was awakened in the room. He woke perfectly, was talking to the anesthetist, no deficit. But the immediate post-op CT.
Arthur, you have two people questioning if you had a brain window on that earlier bone CT in the OR.
Okay, I do have it. I can show it. I will zoom it up just to find it. Do you want to see the whole brain or just the site of the pin? It's likely the site of the pin that they want to see, right?
Right.
Yeah, site of the pin.
Sure.
We can do some windowing here.
So that was obviously part of your decision to go ahead, is that it looks okay.
Yeah.
Yeah.
Sure. That we didn't see any hematoma or anything that could.
Yeah.
Can I make a comment here, Arthur?
Sure, go ahead.
Yeah, I presented my learning curve case with a young girl with a with a bone fracture, and I got the screw into the corpus callosum, and that was a little bit the same thing. I realized after the surgery episode that something had happened, but then it was my third case. It's not so easy to always realize what happens. I realized that the screw was down there, so I discussed with several of my colleagues what to do. And since nothing happened on the anesthesia curve, anything, I continued to place electrodes and made a CT scan for reconstruction and also for a sort of diagnostic possible hematoma immediately, and found no problems. So it's a little bit, I think, comparable to this. And I just discussed and we continued, and I made a restoration for 3 or 4 days, and then gone to sort of final surgery for 3 or 4 days. So that is a little bit of a pragmatic solution of a problem, and I think it's the same as you did. That was everything.
Yeah. Anything else there?
Not for me.
No. So the immediate post-op CT, we took the frame out, of course, and oops, the kid was fine, no deficits. And this is what he got.
Mhm.
That's come from above. You see the electrodes are there, the depth electrodes, the DBS electrodes.
Yeah, so the complication is not from the depth detectors, it is from the fixation frame, isn't it?
Oh yeah, it's not related to the borehole for the depth for the DBS
No,
electrodes.
it's from the frame. It's from the frame, isn't it?
Let's do some windowing here.
I think what it shows us is that sometimes you have to be extremely pragmatic, doesn't it?
So at this point, the kid was doing fine,
Yeah.
no problems, immediate post-op. And then can we get the second question, guy? So with this imaging, immediate post-op, what would you do? Reevaluate the patient frequently and repeat CT accordingly. Remove the hematoma through a borehole, remove the hematoma through a craniotomy, repeat CT scan in an hour or maybe other. I think we could start voting. Please don't be shy, please vote.
Okay, looks like we've got most of the votes in, so let's end the poll and share the results.
Okay, so we are kind of split in here. Likely, but if you sum up through a borehole and a craniotomy, it's removal of the hematoma with the preferred conduit here, but some would reevaluate the patient frequently and repeat the CT accordingly. What we did a craniotomy and removed the hematoma. Although the patient was pretty good, I think it's a pretty big hematoma in a couple of hours. So that was what we did. And I want to show you a late post-op MRI on this patient.
Yeah, were you worried about the hematoma having displaced the final position of that ipsilateral electrode at all?
Yes, actually, I'm going to show the post-op MRI just to answer anatomically to your question. But if you see it, if you see the scan there, and you look into the electrodes,
it's not transventricular.
No, it's not transventricular, but it's you get the feeling. Look at the left. I'm getting down. You see the left electrode, it's a little bit lower than the right. The right start seeing the right one here, and this is one is near the pretectal area, and it's the left one appears to be a little more anterior, so it appears, at least at this early scan with an hematoma, that the brain has shifted counterclockwise a little bit. And that we suspected that we might have issues with electrolocalization because we thought there was a counterclockwise shift of the electrodes. And this is exactly what was shown in a post-op MRI. So what you see here, this is the right one, and this is the left one. This is posterior commissure. So this one is a little bit anterior. It should be here, not there. And this one is posterior to the posterior commissure and a little bit lower. So we did get a brain shift counterclockwise, and in the end, we needed to reposition this electrode. So he got an additional procedure for electrode replacement and retargeting. But fortunately, he ended as one of our best responders to central median DBS, and he's seizure-free after all this mess. So, but in the end, he was brought in for one procedure, and he got an additional one for the craniotomy for the clot removal, and then an additional one 3 months later for repositioning of the contacts.
Arthur, a couple of questions that have been brought in. So John Willie was asking, what kind of frame did you use?
We use a frame called Micromar. It's a frame. The maker is a Brazilian company. It's definitely the most frequently used frame in Latin America. So it's.
And do you know what the pin force is on that frame?
Yeah, there is a manometer there, and we always use the manometer. But for some reason, in this, 14 years old, it's a kid, but in very thick bone. So for some reason, in this patient, I suspect that he has some problems with the bone. It's really rare to get this type of thing.
And just to clarify, when you went back, you revised both electrodes.
Oh yeah, both, because the left one was anterior and superior, and the other one was posterior and inferior. So both of them were not adequately located. And in DBS procedures, either you put the electrodes in the correct place or you're gonna get no results. So we needed to go ahead and do both sides again.
And Professor Rossler was just commenting that it's relatively common in small children to get CSF flow after removing the Mayfield.
Yeah, well, it's in small kids, but I've never seen that happen in children with such a big and thick bone. But it's always a possibility as far as if you tear the dura, you can actually, if it was leaking CSF, it would be better, right? Because if it's leaking CNFs, it would mean that there's no hematoma there. But yeah, that can happen, certainly.
Yeah. Can I make a question?
Sure, go ahead.
I do have two questions for you. I assume that you proceed because you had the impression that the frame was well fixed to the head despite the pain. There was no movement in the frame in relation to the head, or that could also be a possibility for the misplacement of the electrodes. And the second question that I have is related to that. I also assume that we believe that the epidural hematoma was forming during the procedure and not after the removal of the pin, and that's what creates the epidural. So I have those two related questions. So I assume the frame was well fixed despite the pin was in a not optimal position. And second is you assuming that the epidural hematoma was happening during the procedure to explain the misplacement of the electrodes. Is that correct?
Yeah, I'm pretty sure that the frame was well fixed for him. You can get adequate frame fixation with 3 points. So,
I'm just talking about the axial movement of the pin, because now the pin could move on its axial, on its
but even
axis, yeah.
Yeah, that's correct. But even if the fourth pin would move, the other three will keep the head likely in the same position. So I don't think the stereotactic coordinates were let's say damaged by having this pin in. Even if this pin have moved a little bit, the other three, I think they'll do the job. No, I don't think so. And I think we cannot prove it, right? Because we didn't have a post-op CT with the head frame on, so we cannot prove it. But I would suspect that the hematoma formed during the procedure and not after pin removal, because the brain was tilted and the electrodes ended in a bad position. And if the hematoma was formed after the procedure, I suspect the contacts would be in the correct place. So I think it happened during the procedure, making the contacts to be out of target. And then you remove the hematoma, but they were already there in the wrong target. So, but I think it's likely that it formed during the procedure and not after pin removal.
I think Arthur, Professor Rossler may have another comment on your case. Professor Rossler, I think you can speak now.
Yeah, what I saw on the scans was that there is
some problem with the connection.
Please put your video on, Carl.
Okay, just I'm looking where to put it on.
Hold on 1 second. I'm working on it.
Okay, so what I saw is that you had relatively much air within the postoperative CT, which means that the brain had no pressure against the dura, and so maybe this was also a factor that the hematoma could develop during the surgery. Do you normally avoid the CSF loss by plugging the borehole with some cottonoids or even wax or something, or because if the head is not optimal,
hold on 1 second. I'm trying to give him video access.
Yeah, I think.
Okay, here you are. Good.
Okay, so I don't know what you have already heard from my comment.
Please start again, because the connection was very bad.
The comment would be, what I saw is that you had relatively much air in your postoperative CT scan, which means that you lost much cerebrospinal fluid, and so the pressure of the head against the dura, of the brain against the dura, and the CSF against the dura has been very low during the surgery. And so maybe this was also a permissing factor for the hematoma development. So I have done a few stereotactic procedures and many years ago, but I always learned to plug the hole during the procedure that no CSF comes out, also because brain shift would also be bad for the accuracy of the electrodes. How did you do that with the borehole? Did you lose much fluid or CSF?
Yeah, this is an interesting question. We always try to limit the exposure through the borehole to the air. you could fill the borehole when you're not using it with flow seal or any other type of thing, and we usually do that, or sponges or everything. But in any case, you are gonna get air anyway. Can be more air or less air, but in these procedures you're always gonna get air. There are many studies looking into how this amount of air would distort the stereotactic space and lead to errors. The literature is more consistent for a movement disorder, DBS procedure, because the numbers are bigger. But it appears that yes, subdural air could impact on coordinates, but if you are talking about coordinates in the geometric center of the brain, the thalamus, etc., the displacement is less than if you are talking about the surface. So yes, air inside into the subdural space can modify target coordinates, but it's not that much, and certainly not that much as you see in here in the final position of the electrode. So I still think that this distortion is likely related to the hematoma and not to the subdural air.
Yes, thank you. But maybe as a second point, the air and loss of CSF might also have been a permissive factor for the development of the hematoma, because if the brain slacks and comes away from the dura, there's no counter pressure to stop the bleeding.
Yeah, sure. In that sense, I do agree. It's very likely that helped. But if the pin didn't went through, it will be no problem. But since we had that and there were air inside, and meaning that you have a CSF leak, that's definitely that must have helped with the increase of the size of the hematoma. I do agree with that.
But I think it was extremely bad luck, because we do in our department many stereotactic procedures also with frame, and I don't remember that we had such a complication due to a pin.
Yes, I would agree that it's bad luck, but has already been described. And I had a colleague that said that it's good to talk about it because you save on psychotherapy. So it's I do agree with you. It's bad luck, but it's there, and I think it's fair to show it.
Arthur, you have another question from Professor Shins. Would you like to ask that, Professor Shins? Or would...
Yes, good afternoon. Thank you for your very honest presentation. Well, in retrospect, everything is more easy. So when you see this case in retrospect, would you say, when you say another same case with a pin entering the inner tabula, that you stop the session at that moment, do a CT or two, and replan the DBS procedure in a couple of weeks?
Yeah, we have thousands of stereotactic procedures done and never seen this, and this was the first one, and this occurred this July, so it's fresh. Actually, I think it's April, or it's April, yeah, it's April, so it's a fresh one. And of course, you can imagine that after you have some of these things, you might start thinking that if you see it again, you just remove the frame and abort the procedure and do a CT scan and redo the case in a day or two. I would be very reluctant, despite I agree with Carl that it was bad luck, but I would be very reluctant to go ahead with another procedure with a similar finding, because, you know, we get we get you have to be on the safe side. So if it happens again, I would like to just remove the frame, repeat the CT, and do the case 1 day or 2 afterwards.
Thank you.
Shall we move on to our next case now? I believe our next case is going to be Christian, right?
All right, yeah. Can you see my screen? Okay, so I will show you a complication after a death electrode placement in a 27 years old female patient with a left TLE, started seizures 16 years ago. In her history, she had a fall from a horse. Seizure frequency was high. The semiology was typical with post-ictal aphasia. Neuropsychology was unremarkable, some deficits in working memory, and these were her medications. Here is the MRI. So there was a normal mesial and lateral temporal lobe. She had a small temporal encephalocele, as you can see here. The FTG showed hypometabolism here on the left. Sorry, but I don't have the color-coded images. And of course, the speech was on the left side. She also had a post-ictal aphasia, right? So the plan was to do death electrodes to target the size of the resection in this case. So here are the electrodes. We put in 5 electrodes. The targets were the temporal pole, like this, the amygdala, hippocampal head, body, and tail. And she was extubated at 12:45. She was in a recovery room. She was complaining about headaches, was drowsy, confused, paraphasic, and had a low level of consciousness. But the staff there, she was also given opioids, so the staff there was not that worrisome about her. But she continued about her headaches, and the level of consciousness was decreasing. So we opted to get the CT scan 2.5 hours after her extubation, and this was the scan. So you should see the one electrode here, the second, the third here, this large hematoma going up to the posterior temporal lobe. So the question now was what to do in her case. And I think, Guy, you can now pull the first question. Yes. So what would be the operative strategy? Evacuation of the hematoma alone, evacuation of the hematoma and the encephalocele and the pole, evacuation of the hematoma, pole resection and mesial resection, evacuation of the hematoma, leave some electrodes in place because we don't have any results from that side now.
People are still arriving at their decision. We'll give it a few more seconds.
Okay, okay. So the implantation was unremarkable. We didn't experience, sometimes when you do the drill hole, you have these kind of bleedings from the bone, but it was very unremarkable, bloodless, very straightforward. Okay, so the majority, 39%, said evacuation of the hematoma, then 23% evacuation of the hematoma plus pole resection, and now you see what we have done. Sorry. So we went, of course, to the OR, took her to the OR immediately. What we were encountering was an abnormal blood clotting. So we need to give her 2 grams of fibrinogen, 1 gram of tranexamic acid, 600 milliliters of erythroid concentrate. And what we have done is answer C. So we removed the hematoma and the temporal pole. We left the mesostructures in place. The post-op scan was fine. As I said, we had very hard time to get the intraoperative situation bloodless. Her follow-up, early follow-up, she was discharged at day 14, significant aphasic, needed outpatient speech therapy, severe attention and memory dysfunction, was highly depressive, tearful and anxious. We could discuss what is the reason for the hematoma. Is it the inaccuracy from the new navigation-based death electrode implantation? Was it improper implantation technique from the surgeon? Is it a combination? Is it the blood clotting time? Any thoughts on this? Any thoughts on the operative strategy? As you saw, we opted for evacuation of the hematoma plus pole resection because we said, okay, we do have the hematoma, we do have the encephalocele. We were very convinced that the epilepsy was coming from the left temporal side. The hematoma was including the temporal pole, and that's why we opted for this strategy. Any
Christian, there's a question for you as to did you use a robotic assisted technique, or what was the technique for placement?
So this was we didn't use the robot at this case. It was the Medtronic new navigation with the vertic arm that we used in this case, with a surface registration method.
And when you did a post-operative reconstruction of where your electrodes were relative to the hematoma, could you tell which electrode it was and whether there was any issues with targeting?
Yeah, so we analyzed the images, and because of the hematoma, it was very hard to find the exact reason for this, but we thought that this electrode here was the reason for it. But going back to the MRI images, there was no large vein there. There was not, from the circle anatomy, we didn't think that it was a very, dangerous entry zone. We know that we are using the navigation-based implantation method. We know that we were using surface registration. So we anticipated our error margin as always. So error margin is much higher with this kind of implantation method in contrast to using the frame-based, or in contrast to using the robot technique with not using the surface marker, but using, for example, fiducials. And this was the first major bleeding that we experienced now for 7 years in using this method. So we thought we didn't change our strategy and our implantation method. So we are still using a navigation-based method. What we are using now is the robot again. And what we are doing now is we are now very lucky to have an intraoperative MRI. So all cases are done in the intraoperative MRI. And we do have an immediate image with the electrodes in place. Of course, it doesn't prevent the bleeding, but we immediately see then if we have a bleeding or not and can immediately react. So in her case, we had 2.5 hours of a delay. But of course, the intraoperative imaging doesn't prevent the bleeding itself. The only thing that we changed now is, I didn't mention it till now, that the blood work was done 2 months before surgery, and it was normal. But we don't know what was happening intraoperatively because the blood clotting was very, very bad. So what we changed after this complication, what we have learned is that we do a blood test the days before surgery. That was the the lessons that we learned from this complication. We didn't change our implantation method, and yes.
You have a couple of questions from I think Massimo Casu has a question for you, and then Professor Rossler.
Please.
Hello, Chris. Thank you for your presentation. And my question is, do you perform X-ray rotational digital angiography before implantation to plan? And my second question is, I see from your pictures that the course of this electrode is slightly deviated from a straight course. So it may be that there was a problem, not with the entry, the very superficial entry point, but with some vessels located inside the sulcus. Don't you think that? Yeah,
probably that was the reason. So what we do, our protocol is to use T1 plus contrast as the basis for planning our electrodes. We don't do digital angiography. What we do is we try to avoid crossing of any sulci. We try to anticipate the error margin at the entry point. So the error at the entry point is between 2 and 4 millimeters, I would say. So we try to, if we choose our entry point, to take the crown of the gyra and not to be too much nearby the sulcus or a cortical vein. As I said, we try to avoid crossing of sulci, and with this kind of concept, this was the first bleeding after 7 years or so. So we think that we still think that the navigation-based method is sufficient, but I think the surface registration is not optimal for doing the death electrode implantation, and we're doing the fiducials right now, simply because the error margins are less, but we are still not using dedicated vessel imaging, so just the T1 plus contrast, with the concept not to cross the sulci.
Christian, I think Professor Rossler had a hand raised.
Yeah, maybe I can add some comment. The other question which should be asked in this case is, was it really necessary to implant her with DEF's electrodes? And I made myself some self-accusations about that, because during the 8 years I was in Erlangen doing epilepsy surgery, we had 10 patients with temporal lobe herniations. And in these patients, we had 8 patients who became seizure-free after doing a pole resection and resecting this encephalocele, this herniation, and they get seizure-free. We had 80% seizure-free patients by operating on this pathology with a widened resection of it. But in this case, our epileptologist was not sure if she has a neocortical or a mesial epilepsy. But one could also argument if she had a mesial epilepsy, we also shouldn't have done a WADA test or another investigation to prove that it is possible to resect her mesial structures. So we also, in this case, I'm now convinced we also should have primary done a pole resection and removing the encephalocele, and only if she hasn't become seizure-free from this surgery, we should have done a second investigation with the DEPS electrodes.
Yeah.
Christian, I think also Nico Enslin had a comment and question, and Nico, you should be able to speak.
Good afternoon, everyone. Thank you so much, Christian. This is incredibly, I think, brave from everyone to give these talks, and it's incredibly valuable just to see that things like this happens to everyone, even to incredibly experienced people like you all, and that's very helpful. One of the things I wanted to ask is I think your case is very much akin to doing a temporal resection or an awake craniotomy for, say, a difficult tumor or a difficult epilepsy case, and then during doing your craniotomy, you plunge with the burr hole, as an example. I've had a case that happened to a very senior colleague of mine like that about 10 years ago. And it opened up this whole discussion of what do you do then? There was clearly an injury right over potentially motor cortex in the patient from the burr plunging. The clutch mechanism failed and it didn't stop as it should. And what do you do then? Because you counsel a patient for your resection and you plan everything for your, like you said, you do incredibly detailed planning for every single depth electrode or stereo EEG case that you do. But then the discussion comes up, if you now continue with operating, you add the risk or the deficit that the patient might have related to your operation to this complication that you had. So suddenly you're dealing with two big risk factors, and I almost wonder whether it's competing against each other. My thought would be, and what we did in that specific case, and I'm asking, I don't know what other people would do, was to rather say, let's stop here. There is a complication. Let's wake the patient up and see what the deficit and the scan is related to that burr hole plunge, and then deal with it separately, and in another sitting then do the epilepsy operation or the tumor operation. And I wonder whether an option would be plan E or option E on your options, to say, well, deal with the complication, remove the hematoma. Clearly the patient is symptomatic, but maybe leave the electrodes there, but stop there and try not to add, especially like you say, you had a clotting disorder. But sure, it's an incredibly difficult scenario. Yeah, thank you. I'd love to hear what everyone thinks about the thought or how one deals with cases like this, because it's not impossible or infrequent even, I think. Thank you.
Yeah, thank you, Nico. So the patient, she's seizure free, okay, but she's still not comfortable with the situation and is still blaming us because she didn't consent for pole resection up front. Okay, so we evacuated the hematoma, we did a pole resection, she's seizure free, but still she is very anxious, tearful, and is blaming us because we did something additional, even though she is seizure free now, right? So difficult situation.
We have another couple of questions from Professor Pissarro. I don't know you, but if I'm correct, you're a neurologist who runs an epilepsy surgery center, correct? And you had an imaging comment or question?
Yes. I'm a neurologist that works closely with my adult and pediatric neurosurgeons. So we had a complication a few years ago that had to do with the position of the patient. We placed stereo G electrodes, and we placed the patient in the prone position. And when we looked at why our complication occurred, actually we reviewed it with Chico Cardinal, and what occurred is that our preoperative vessel imaging was done in the typical supine position, but we placed electrodes posteriorly, and the patient was prone. So what happens is the vessels shifted by a few millimeters. So even though our planning was fine, we actually pierced the vessel and caused a very significant complication. Fortunately, she survived that complication. So we learned, never to put the patient in a prone position when putting in electrodes. And even when we do posterior electrodes, we put them in actually lateral oblique and not going a posterior approach. So, but anyhow, as a result of that, we even revised our protocol, and we started to use, based on the paper I put in the chat, MRA with delayed MRV, and also CTA with delayed CTV. And so what happens is you start to scan 20 seconds after it, 20 to 24 seconds after the contrast reaches the ICA. And it really gives us superb vessel imaging that really helps us in our preoperative planning with SEGs to kind of avoid critical blood vessels better than you can get with MRI with contrast or CT with contrast. And that's actually served us well. And there's a paper, the reference that I provided in the chat.
I think that there are a lot of different ways that people image. Obviously, Chico, and I know Massimo can comment, but Chico still uses and believes very strongly in conventional angiography. I think most people in the US do not use conventional angiography, but use various images of MRI, MRA, CT, CTA, CTV, and everybody has their own little tweaks to it. But the reality is, I think that everybody would agree, no matter what you do, you're not immune. And at some point, if you do enough of these, you're probably going to have a bleed.
Yeah.
Yeah. I think there's a lot to discuss, but maybe you need to move on, Guy, because I still have 2 more cases, right?
Yeah, but if we can always extend, right? Jorge, do you want to go ahead?
Yeah. Oh, I think this, sorry. Just 1 second. There we go. Very good. Can you see my slides?
Yes.
Very good. So very briefly, I would take 10 minutes. It's a complication or complications in temporal lobe resection. I will present a 20 years old patient, right-handed, with a duration of epilepsy for 4 years. As history of semiology, he has depression, and his seizures are characterized by scaring feelings, anxiety, feeling of sudden feeling of fear associated with tachycardia, and then a generalized tonic-clonic after. He is highly severe with several admissions to the hospitals because of status epilepticus, because of that. He is medically intractable, and he currently is taking lacosamide and Depakote. I mentioned to you the panic feeling that he has associated with tachycardia. He also has this facial flushing, sweating, and generalized tonic-clonic. The last generalized tonic-clonic he has, status epilepticus, was a seizure that he had in the EMU with approximately 40 minutes of duration, just to illustrate how severe this patient is from a seizure aspect. Some non-invasive data, the scalp EEG shows spikes, interictal spikes in the temporal chain. The ICTA recordings also showing evolution of seizures coming from the left side temporal lobe, which is his dominant side by headness. The MRI was read as normal or non-lesional. I just want to show you this picture to see that there is a question mark about the volume of the amygdala and increased changes in the flare signal on the amygdala on the left side, which is concurrent with the non-invasive data and also for the hypothesis based on his semiology. The PET scan shows hypometabolism in the temporal lobe, what was diffuse, involving the temporal pole, the basal, and also the mesostructures on that side. And the MAG scan was not contributory to the understanding of the location of the epileptogenic zone with multiple dipoles bilaterally. So we had our hypothesis. This is a left mesial temporal because of the semiology, mostly amygdala, maybe involving the anterior percussive areas, maybe involving the ventral insula. And in order to continue, I think we have a question. So Guy, I don't know if you want to put the question on the poll. The question here is quite simple. This is most likely, in our view, a patient that requires an SEG evaluation. However, the patient is taking valproic acid, which is known to affect coagulation. His pre-op coagulation tests, including platelet functions, were completely normal. So would you, as to proceed in this case, would you stop valproic acid and perform a temporal resection, or with temporal resection without changes in medication? You perform an invasive monitoring without changes in medication, you stop the valproic acid and perform invasive monitoring, or acquire additional non-invasive data and hold down surgery at this point?
Let's give people a few more seconds because complicated question.
Sure. The question is related to the surgical managing under valproic acid in a severe epilepsy with risk for status epilepticus.
Okay, let's see what we have here. There you go, Jorge.
Very good. Very excellent. So most of the our attendees, they made the option for question D or answer D, stop valproic acid and perform invasive monitoring. Very good. This was what was intended in initially.
Jorge, I think it's important to point out that this question probably has greater disparity of answering than any other question we've had today.
Yeah.
There's almost 20% on all 5 choices.
Very well said. Yes, absolutely. It's controversial for sure. And I will show you what we did. And of course, I don't like to operate under valproic acid. We asked our colleagues from the clinical team to stop. And because of the risks of status epilepticus and the high severe seizures that this patient had, there was a high chance for him to develop status if we try to change the valproic acid. So we decided to operate this patient, and having that his pre-op testings were normal, including the platelets functional, we decided to proceed with this patient under valproic acid because of the challenges in withdrawing the medication for him. Let's see here. Yeah. So we very briefly, this is the planning of the temporal percussive implantations that we perform with him, with electrodes in the amygdala, temporal pole, entorhinal, head, and tail hippocampus is also in the percussive compartments, supra and infrasylvian. And this is the intraop picture of the SEG with orthogonal electrodes with no complications intraop. The implantation was smooth and with no challenges. The post-op CT shows no hematoma. The interictal activity of this SEG reveal the presence of frequent spikes in the amygdala, in 2 different regions in the amygdala, with some also spikes less frequent in the head of hippocampus. This is the conclusion of our interictal activity. Most of the spikes were coming from the amygdala with some interictal spiking in the mesial structures of the temporal lobe. And the ictal, the location was, let me show here. Very good. This is the recording of the interactivity. This is patient was asymptomatic. We see the evolution of the interictal spikes transforming or evolving into interictal activity. Patient had an arrest of movement. When this activity in the L and A prime had evolving, the patient developed the anxiety feelings. This was associated with also involvement of the mesotemporal lobe structures. And once this activity reaches the basal temporal or the ventral insula, you start having some heart rate changes, and this evolves with more amygdala and pericerebral involvement, and finally, the patient had a generalized tonic-clonic seizures. And this is the end of the seizures. So in our view, we concluded, we did one more step, which was the electrical stimulation, and we stimulate the head of hippocampus. We stimulate several contacts, but specifically for the head of hippocampus, contacts 3 and 4, we did 1 Hz with 500 microseconds at 4 milliamps of amplitude. You see the stimulation of the head. Immediately, there is an activation of the amygdala on the both electrodes A and prime and L prime, with upcoming of the semiology with anxiety and finally developing tachycardia and generalized tonic-clonic. Our conclusion, this based on this ECG, was that A, this is amygdala temporal pole epilepsy, and a resection of the amygdala temporal pole would be necessary. And the second question is if the hippocampus was involved or not. Because we didn't have very good decisions to, or maybe reasons to remove the hippocampus. This was non-lesional hippocampus. This was a patient with a completely normal verbal memory, and the invasive monitoring with the ECG suggests more amygdala than hippocampal structure involvement. We decided just at this point to resect the amygdala and the temporal pole with preservation of the hippocampus. So very tailored resection for him, with the fact that we explained to him that there is a chance that we will have seizure recurrence, and perhaps in the future, this hippocampus may need to be resected, but we decide to preserve it at this point. This is the immediately post-op MRI showing good resection with no complications. After 48 hours, she started complaining of headaches, intense headaches, and finally having 2 or 3 generalized tonic-clonic seizures in a period of 10 to 15 minutes. We decided to transfer him to the ICU, and then finally got a new imaging, in this case, a CT. And this is the picture that we see. This is intraop or intracavity hematoma in the cavity resection on the left side, left temporal pole. And this patient with recurrent seizures, highly recurrent seizures, being transferred to the ICU. So then it comes for the second question, how to manage the complication. And the complications here are 2, is number 1, the presence of a post-op hematoma, delayed hematoma. Should we do a conservative, and the second complication is the presence of recurrent seizures after, with the hematoma. So conservative treatment, observation, and withdraw the valproic acid. Conservative treatment with observation and maintaining the valproic acid. C as a surgical evacuation of the hematoma. D, surgical evacuation of the hematoma and resection of the hippocampus. And E, none of the above.
Let's give it a few more seconds for people to answer.
Sure. So again, hematoma under valproic acid with the worsening of seizures after, that could be caused by, number 1, the hematoma contributory, or because we left the part of the epileptogenic zone / the hippocampus behind, and what we do next. Excellent. I think most of the group, most of the attendees decided to surgically evacuate the hematoma. And this is exactly probably the safest thing to do. We decided he was having headaches and worsening seizures. We decided to observe him for an additional 24 hours instead of removing the hematoma. So that's what we did. So we keep him in the ICU. We didn't withdraw the valproic acid. We transfuse him with platelets, and we add a TERF antiepileptic seizures. He did well. He was stable during this course. In the next 24 hours, no more seizures. He's being seizure-free for 6 months at this point, with no other complications. So I think this case illustrates again the complexity of operating patients with valproic acid. Of course, we need to, when possible, we should withdraw the valproic acid, but in some circumstances, for example, in this case, this is something that is difficult to perform because of the severity of the seizures. And in that way, we decided to go ahead, had a complication, but luckily this patient did well. So this is it. I will open for further questions.
I think Professor Shins has a question for you.
Yes, thank you, Jorge, for the presentation. We also have, well, of course, many patients with valproic acid, and we made an arrangement with our hematologists. We made a decision tree, and because many of our neurologists don't want to stop with the valproic acid. And then we spoke with the hematologist and told them, well, are there certain tests to do? Not only the bleeding time, but other tests for testing the effect of valproic acid. And they said, yes, we can do a lot of tests. And now they developed, I think, more or less 10 or 12 testing procedures with the valproic acid. The patients come into the hospital early in the morning, and 2 weeks later, we have the test results. And when the test results are normal, we do every procedure with valproic acid. When the test results are not normal, we ask the neurologist once again if we can stop and taper off the valproic acid. When not, then the hematologist gave us different advices to proceed during the procedure.
Yeah, so thank you. So I forgot to mention, I think this is very helpful, and we did consult hematology for this case, and we did all the tests that they requested, and this patient was cleared for surgery by hematology. So I think another learning point for us is there is no enough sensitivity in many of those tests to prevent us or to predict if this patient is going to have a complication with valproic acid. The safest thing is to stop the medication. But even if you have a clearance from hematology, this does not completely put us in a safe position to operate the patient. So there is always this concern regardless. I don't think we have a good test to understand what is the impact of valproic acid in platelet functions in neurosurgical procedures.
Jorge, can you comment a little more on what you found in the operating room? Was the brain coagulopathic? And at the time in the OR, when you repeated the testing, did anything come back normal or abnormal that had been normal before?
No, the surgery was uneventful, Guy. However, you had the feeling that this was a more oozy brain than normal. We were able to control any oozing in the intraop. So in the end, the aspect was quite satisfactory. And we did post-op tests also, and everything came back normal, including the platelets function. But we didn't want to take any chances, and we decided to transfuse him with platelets regardless of the lab results.
And Professor Shins, if you're still there, one of our participants, Dr. Cervantes, would like to know if there's any specific tests relative to valproate that you're ordering with your hematologist.
So there are specific tests for, and specifically we are testing for platelets functional testing, which is a battery of tests that they do.
And Professor Shins at your center?
Yes. We are submitting a paper now for an analysis of our cohort of about 100 patients, and we saw in about 50% of those patients we saw a thrombocytopenia. That's a lot. So the clinical consequences, you can doubt about it, but 50% of the patients, and especially the children, had a low fibrinogen in their analysis, a low fibrinogen function. So I cannot recall at this moment because all those tests are about 10, 12 tests they have special names, LTA test, I think, and but we are publishing it, and when you would like, I can send the paper after acceptance.
Just to mention that, of course, this is not a new discussion. It's been there for many years. In our publications on practice in epilepsy centers around the world was kind of a 50-50 thing. 50% of the centers withdraw valproate and the other did not. And the problem is exactly what's been discussed. It's mostly a platelet function issue. It's not always a question of the number of the platelets or other things like fibrinogen, but it's more often related to platelet function. And as far as I can tell, there's no adequate platelet function testing, but there are some, but they are not, sufficient. And it appears we look into the numbers that we will need to get the results in terms of the power of the study, and we got that we will need thousands of patients to prove one thing or the other, and I think it's not feasible. And it likely means that whenever possible, it would be useful to withdraw valproate. We receive a significant number of patients with generalized refractory generalized epilepsy, and many of these kids are taking valproate, and it's the best drug for them, and so it's difficult to withdraw. But in people with focal epilepsy, where valproate is not a good drug, I would suggest, and what we do is we remove valproate in focal epilepsy patients, because you would be able to find a drug with a similar seizure control, and it's just likely dangerous not to withdraw it. So I would suggest that you not have literature to support in terms of level of evidence, but cases like this always raise a question, and then I'll get the question back to Jorge. If you receive a temporal lobe patient with valproate again, would you go ahead even with any hematology result, or you say no, just remove it, withdraw it, and go ahead in 2 weeks?
The answer is very simple and very clear in my mind, Artur. We should not operate patients under valproic acid, period. I think it does carry a degree of complications. The question, it becomes more complex when you have this type of patients that patient that came to you under valproic acid, very severe with a lot of status epilepticus, where the epileptologist is truly concerned that if we just by the fact that you change the medication, this patient can go to status again and increase the morbidity. So we have like a catch-22, and it's a difficult situation. Sincerely, I don't think I would have done anything different from this patient. Is that the team needs to understand that assuming those type of severe cases that there is an increased risk for complications in those patients, and eventually do our due diligence, testing the functional test, get a hematology consult. But even with that, I think our rate of complication will be higher for those patients, regardless what we do.
And Jorge, Professor Al-Arabi was asking, if you transfuse, in a situation like this, do you transfuse platelets pre or intraoperatively independent of the test results?
So this is something perhaps I would have done a little bit different. For this case is the transfusion during the procedure itself. We end up transfusing him once we identify the hematoma, but perhaps retrospectively we should have transfused him in the OR once I had the impression that the brain was a little bit more oozing, and maybe I should have asked for the transfusion in the OR. Maybe that would be preventing the hematoma.
And I think also you have a situation where you've made it through an SEEG without any complications. And so, you know, with all those electrodes going in and no bleeding, at that point, you think I'm going to be okay.
Yeah.
Maybe I can add a comment. In our hospital, our hematological laboratory uses a test. It is called PFA 100. Maybe it's the name of a machine which is doing the test, and it's a kind of thrombocyte coagulation test. And this machine is also in test is also used for excluding patients having taken aspirin. And this is the one point. And the other point is if in this patient it was a simple venous bleeding after surgery, which accumulated during the hours after the surgery, which we found also in glioma surgery or other common surgeries, which has nothing to do with the valproine. And maybe as a third point, I think in Austria and in Germany, in my experience, there is a kind of agreement or even guideline that we don't operate on patients taking valproine.
Yep, I think those are important points. I think this was a small, slow rate oozing from the venous system. We didn't see anything immediately post-op. Everything was okay. But I think the valproic acid was contributory to this continuous oozing, and I think that is probably what was the reason for the formation of this hematoma. Another concern that we had is that we had this hematoma and you have worsening seizures. So now it becomes, this hematoma is contributing to the worsening seizures, and now that's the reason to evacuate the hematoma, or because we didn't resect the hippocampus, and that was another complexity in this patient. But in the end, conservative treatment was the right option for him because he became seizure-free and he passed this acute phase and did well.
So I think, Guy, you should, you do have a case.
Yeah, Arthur, I'm going to have to do it a different time. I've got to run.
Okay.
Apologies. I think we should have more sessions where we have people discuss interesting, frank complications, because we all have a ton to learn from each other's experience, and this doesn't always make it into the literature, nor does the conversation.
Yep.
Right.
Okay, so thank you so much for everybody to being here. It's very